Have we got time for questions?
Even on like an hypertrophic training,
Yes.
instead of isometric and or maybe combined with aerobic activity.
Certainly. Most of our patients will be having low muscle mass. We DEXA, dual energy extraabsorptiometry, every patient that comes in clinically to get an indication of their body composition. The majority will have low muscle mass. I've got a patient, which I'll see next week in London. She is at the 2% of sarcopenia. She's in the bottom 2% of muscle mass for her age. That is a major problem. We have to address that. Definitely, we use all of the tools at our disposal to try and produce muscle hypertrophy. We use blood flow restriction, for example. So that's where you put a cuff on to reduce the blood flow. It's used a lot in different patient populations. Certainly bodybuilders and powerlifters have been using it. We use accentuated eccentric, okay? The majority of our resistance training is dynamic. It's not isometric. We only use the isometric when you have problems of bone metastasis, okay? So we use everything we possibly can to grow muscle. We supplement with protein. So most of our patients, we try to get them to about 1.6 grams per kilogram body weight of protein because many will have poor absorption. They don't have, their appetite is gone. They may have vomiting, diarrhea. So we try to get that protein into them. Yes. Sure. I've only done one clinical trial. We did it in glioblastoma, and we had really good success with that. It's a very interesting one. Most people avoid it because it's very difficult. The patient survival is very poor. Most research has been done in breast and prostate cancer because they're so common, less so in brain cancers. We've just finished a study in children. Most of those children had brain cancers. That's just the way it is, unfortunately. These patients can safely exercise. There's not a problem. I think one of the key advantages, particularly in terms of the brain, is the exercise lowers systemic inflammation, and that's of benefit to the brain. Also, we published, we have a paper in review at the moment where we're looking at the influence of exercise in lowering systemic inflammation and oxidative stress in the body, which seems to have benefit for those with brain tumours as well. So if you have more oxygen to the brain, you have less systemic inflammation, it seems to actually produce a benefit for the brain as well with their tumour. But there's not a lot of work done anywhere. Yeah. Yes. Ischemic heart disease, yeah. Probably exercise as a medicine has been most applied to people with ischemic heart disease. So cardiac rehabilitation was pretty much the first application of exercise as a clinical therapy. So that volume of literature and clinical work is very, very large. We now know that patients with ischemic heart disease can exercise safely in the right environment. In fact, exercise is a requirement for those patients. It's absolutely critical. Anyone post myocardial infarct, heart attack, must exercise as soon as possible. In the old days, when I started in this field, they were told to rest. 6 months later, they had a repeat heart attack or they were dead. All right, that has changed entirely. Your patient has a heart attack, they're up and they get them out of bed as quickly as they can. We move quickly. And also resistance training. High intensity interval training is being used extensively with those patients. The same thing in cancer. A lot of our patients are older. A lot of them will have ischemia. And so, again, we're exercising absolutely. In the right environment, you don't have them exercising at home alone, okay, preferably in an exercise clinic, supervised. Yes.
Thanks for the presentation, really interesting.
Thank you.
I haven't understood the part in which you explained the difference in vascularization between the normal tissue and the tumoral tissue, and how exercise impacts this difference. And the other question is, what's the compliance, the patient compliance, when you explain that exercise is useful?
Compliance.
The compliance, sorry.
Sorry, no, that's okay. I'm Australian, so English is my second language. Because I speak Australian. So to your first question, tumour tissue grows very, very quickly compared to normal healthy tissue. And if you like, the blood vasculature can't keep up. There's a whole range of other reasons why it's just basically unhealthy tissue. And so the actual arterioles, the capillaries and venules, they don't have the processes to develop properly. Also, the blood flow is low. One of the main things that produces a nice, healthy blood vessel is the pressure, that change in pressure with each pulse. That creates nitrogen oxide, which actually causes the cells that line the blood vessels to be healthier and to grow and to produce a nice organised blood circulation. That doesn't happen in tumour tissue unless the patient exercises. If the patient exercises, then you have much larger pulses of blood through the tissue, much better perfusion. So the blood vessels are healthier. They're not perfect, but they're healthier. And so the blood flow is higher. To your compliance question, look, people say, oh, people with cancer won't exercise. Our patients exercise. We're seeing 80% or higher compliance and adherence to exercise programs when they're supervised. If they're at home alone, the compliance is very low. That's why if you give them, this is the American Cancer Society guideline. The American Cancer Society says you must exercise every day. They won't do it. If they are supervised, even remotely using telemedicine, they will exercise. And as I say, we have 80% plus in terms of compliance and adherence. It is very high. That is higher than many drug therapies. Compliance to statins, for example, for high cholesterol is down around 60%. So people who say, oh, people won't exercise, no, that's not right. In the right environment with the right behavioural change models, they will exercise. Cancer patients are more likely to. People with type 2 diabetes, for example, very difficult to get compliance because they don't feel unwell. They haven't got death staring them in the face. Person with cancer, they come into my practice and they say, what do you want me to do? I want you to run into that wall. How fast? Time. Says, they say, how fast do you want me to run when I hit the wall? Because they're scared, they're dying, they could be dying. So we find compliance very, very high. Yes, nice loud voice. I'm old and deaf. Ah, I didn't explain that very well. So we use auto-regulation with athletes. We've used it for decades. Okay, the athlete comes in, how you feel today, and then we decide. We do the same with the patient. Patient comes in, how well did you sleep? Mrs. Jones, how is your pain level? How energetic or how vibrant do you feel today? If the patient comes in and goes, I feel pretty good. And we've got moderate intensity continuous training program. No, we're not doing that. We're going to hit the weights. Okay, so we're going to do high intensity stuff. If the patient comes in, they go, how do you feel? Dreadful. I had my chemo infusion 3 days ago. I'm just shot. Look, I don't really want to train. Okay, all right. If we had HIIT training, high intensity interval training, we'll say, no. Let's just get on the bike and we'll do some gentle exercise. Not gentle exercise. We'll just do some continuous exercise. The beautiful thing about exercise is that you get lovely drugs released when you exercise. Endorphins, cannabinoids. These are strong suppressors of pain. Okay, now this is a natural evolution of the human. If you had a tiger chasing you, okay, it's no time to worry about your sore leg or the fact you've got a headache. That's bad luck. Okay, what your body does naturally is, okay, I got to run really fast. What it does is it releases drugs into your system, which really suppress pain and nausea, and they lift your mood and they make you more aggressive. Okay, so what we do is we come, okay, Mrs. Jones, should have a nice Italian name, shouldn't I? Natalucci. I said, oh, this is Natalucci, please. Oh, not well today. Look, tell you what, why don't we just do one set of resistance training? You're here now, and then you can head home. Oh, okay, Dr. Rob, I'll try that. They do a set. They go, how do you feel? Unwell. Malato? Malato. Oh. All right. Well, what about? Do you want to do one more set? Do you want to go? Oh, no. I'll do another set. We'll do another set. Drugs start to get released, and then they go. Would you like to go? Oh, no. Maybe I'll do one more exercise and then I'll go home. 8 times out of 10, I find my patients do the whole workout. Now, some of them just go, I'm just too unwell. You know, I've got diarrhea. I didn't sleep all night. That's fine. Let's just we'll do perhaps some mindfulness, some meditation work. We'll do some stretching, something like that. But that's unusual. So that's what auto-regulation is. Is there any questions online, perhaps? I'm not sure. Oh, nice. Ooh. No? So, yes? And nice loud voice. I remember I'm deaf.
There are specific part or specific time of day in which to do exercise.
Yes. The best time of day to do exercise is the time that you will exercise. The most important thing is they do it. Okay. So whatever suits for anyone. You have diurnal rhythms. There'll be times during the day when the patient will feel a little bit better. Of course, not like us, the patients who are undergoing, say, chemotherapy, some parts of the day they'll be absolutely smashed when their diurnal rhythm's down. So you don't say you have to exercise at lunch. No. All right. Maybe mid-morning when their sort of diurnal rhythms are, they're not so nauseous, they're not so fatigued. That's the time to do your exercise. We also break the exercise down. So we do microdosing. So they might have, let's say for round figures, we want them to do so many sets of squats during the week, okay? Body weight squats. So we might break it down and say, look, if they've got overwhelming fatigue, you say, just do 10 in the morning and 10 at lunch and 10 in the evening, okay? We call that microdosing. Main thing is they do something, all right? Sitting on the couch watching Netflix is a recipe for disaster. Right. Yep. Hello.
Does that have a negative influence on the exercise effect?
It does if they're not getting sufficient energy and calories. The problem is 2 in 3 patients with cancer will be overweight or obese. So the other thing is that exercise is a powerful suppressant of nausea. Okay, so we find that patients who are having trouble eating because they feel unwell, when they exercise, they will actually be able to eat more. So that's another benefit that they get. We watch their diet. I haven't talked anything about nutrition because it's not my field, but we spend a lot of time sorting out the nutrition of the patient. We do a lot of work around supplements. If they can't eat properly, because a lot of them can't eat properly, then we do a lot of work around supplements to try and lower systemic inflammation, to try and create more antioxidants within the body as well. So nutrition in cancer is a whole massive area. And relaxation, stress reduction. If the patient is scared and anxious, cortisol levels are high, very difficult for them to respond positively to exercise. We spend a lot of time on the mental side of things as well, around decision regret, fear of dying, those sort of aspects. Because if your patient's stressed out of their mind, very difficult to get them they'll exercise, but they don't respond very well. Okay, I think that's everyone. Thanks so much again. It's been a pleasure. Thank you.
We also to say thanks again because we were excited by your lecture and here in this room, most people are PRN physicians or components of the rehabilitation team, so they are so easy to convince that exercise is a medicine. But I trust that anyone else has been convinced about your argumentation, and I really appreciated all your studies providing a solid background, the rationale behind the effectiveness of exercise. I believe not only in oncology diseases, but in all other diseases. I'm a neurologist by background, and so I'm really convinced that exercise is also the best medicine to face all neurodegenerative disorders, and not only those. So thanks a lot, thanks again, and thank you for being here listening to Professor Newton.
Thank you.